This is the guy from 94. Yeah.
Wow, that is really close to my face. I mean, I'll scoot over too.
This is recording my class. Okay, we don't have to have it on, guys. Let's do this.
Yeah, that's better. Thank you.
I'll keep my shoes on. This guy right there, see how it's all lit up in blue? If you answer or ask a question where Matt is or April, it should pick it up. So during class, if you're wondering what did they say, you will hear it because Diane did it and she like almost was a whisper and you could hear what she was saying because we were testing this out. But hopefully it's better. Okay. Did everyone get a clicker? Probably not. You guys
Okay, you look so sporty.
Oh, it's up to her.
Oh, wow, great.
What is Davy Jones? Who's Dave? No, I said so does Dave. Oh, yeah, I know. You guys all have one?
All right.
I don't shoot the longest I've ever shoot in my life.
All right, we kind of finished on here on Monday, and we just briefly discussed that this is kind of what an aneurysm would look like. It can be anywhere in the body. It can be in the brain, which is what we're going to talk about today. But it also could be inside your aorta, like your descending aorta. It can be anywhere in the body. Basically, all it means is an outpouch, and it's not that perfectly nice cylinder look. And blood can get dislodged in those areas and can cause clots, and it can also cause a rupture and bleed. So different areas can cause different problems. And we'll talk more about aneurysms today too. But just kind of gives you an example of what it looks like. Okay, so CVA, we talked just briefly about ischemia and also hemorrhagic strokes. We're going to go in depth today about how those come to be and also how we treat them as nurses and what we'll see on presentation. Obviously, everyone knows strokes, how they derive, right? We've been through this many times of genetic reasons, environmental reasons, age, but these are probably the top ones they've seen and have found research from of what have actually caused your blood in your body to become more viscous and thick, and it can cause clots. Okay? AFib, if we think about how that works, we're going in and out of that sinus rhythm. That can happen too, where you're going into an irregular rhythm and then back to a sinus. It can dislodge those clots through the body. Hypertension, when we say hypertension, we don't mean 140 over 75 or 140 over 90. We're talking about 200 plus over 100 plus, okay? Those are what can cause strokes over long periods of time. I'm not saying that if you're in the 140s over 90s for 40, 50 years that you couldn't have high risk for stroke, but you have the highest risk when you're over those ranges, okay? Atherosclerosis, that's just that plaque buildup. That can be from fatty diets, eating increased cholesterol, and then making sure that you're having good diets, like not the red meat, like you would see in this area, potatoes. Those are things that they highly recommend you stay away from and be more on a plant-based diet. Measuring your cholesterol levels, that's part of any insurance if you have a pretty good insurance where they'll measure your cholesterol levels, I think it's once every 3 years if you're not a high risk. But they can do that, so then obviously they do that for reasons of your insurance, so they don't have to pay for you later, okay? So it's definitely a screening method. If you've had a previous stroke or a TIA, remember the TIA is the small little strokes, and that can be from a start in the body where you might have a little bit of plaque buildup or potentially a spasm in one of those vessels. That can definitely cause you to have a higher increased risk for stroke. Any type of bleeding disorder, previous surgeries, if you had a knee surgery done or some type of orthopedic one done, you can have a high risk for clots, and that can cause strokes as well. Diabetes, that's with the circulation. Think about neuropathy, you're not having you're not having that good circulation in your extremities. That can cause stroke as well. Smoking, pretty obvious. Obesity, that kind of derives too with our atherosclerosis. The more poorly you eat, the more so you can bleed. Birth control, I'm sure you've heard that too if many of you are women. Going to the doctor, if you are on birth control, they tell you not to smoke because that can increase your risk of a stroke. If you have a parent that had a stroke before the age of 50, or sometimes they're saying 65 now, that you may have an increased risk for a stroke as well. Because genetics are finding you have increased risk for stroke if it's younger in life. So if your parents or a first-degree relative, like a sibling or a parent or a child has that, you could potentially have risk for stroke. Migraines are a little, I wouldn't say as common, only because it deals with your circulation. That's why you have that pounding headache. That can cause a stroke in that regard, but it would have to be repeated and very extensive migraines. If you're a male, or if you're over the age of 60 years old, you are a high risk for a stroke, okay? And if you're any of these ethnicities, so Black, Hispanic, or American Indian, you would have a higher risk. So a white woman in her 40s probably doesn't have as a high risk as someone that maybe is a Black male in his 70s that is a smoker, okay? So it definitely comes down to your unmodifiable risk where you can't actually change those things. So just being a male, elderly Black male, you're going to have a high risk and you may not have any of these other problems, okay? So it comes back down to genetics. So as we are educating our patients, especially in the hospital when they're in for these circumstances, if they're in for a heart attack or in for a stroke, we have to be educating them on why they may potentially have gotten that stroke or heart attack. It's not time to scold and say, you shouldn't have done this, this is why you have a stroke or a heart attack. But we need to let them know that avoiding these certain circumstances will prevent future problems from occurring. They have to get on a good diet, preferably less red meats and high cholesterol foods, or else they will increase that plaque buildup again and they can have more strokes. Alcohol, drugs, obviously those are things that we think of no-brainers, but most people, they might have a cocktail every night with supper, okay, or 5, depending on the patient. And so educating them on proper habits is what you need to do. Weight control, we base everything on BMI. I'm not a huge believer in BMI, but BMI is the baseline for everyone. So we consider obese greater than 30, and we like to see under 30 BMIs for patients with histories of strokes. Hypertension, using their medications properly and taking them on time is appropriate. Some of these people can't afford their medications, so we might have to consult social services or someone to help them with their prescription med, because it's maybe not a term of them being able to take them, it's affording them. High cholesterol levels, if they're going to take a hyperlipidemia med, making sure that they're taking those low. And then controlling their diabetes. The higher risk of diabetes is the higher risk that they go up and down. They're going from low to high consistently. They can have high risk for blood in the body not being able to clot properly or throwing clots. Okay, so this can be in either type of stroke, hemorrhagic or ischemia. Okay, so you can have a left brain stroke or a right brain. Some of you have probably heard that on MRIs before. They have it in the left hemisphere of their brain. So what are things that you have seen in the past potentially from a left brain stroke? Do you remember a patient that had a left brain stroke or what you saw? First things first, where is their paralysis or weakness? The right side. It's always the opposite. And most of the time, everything on that side is affected on the opposite side. So if you assume they have a left hemisphere stroke, so on this side, they'll have right all the way down weakness or paralysis if it's worse enough, and they won't be able to use those sides of the body. Okay? They can have something called, and I'm going to butcher this word, but hominis hemianopsia. And basically what that is they only see out of half the visual field of their eye of the side that's affected. And we'll look at a picture. I just added this so you guys can see it. It's very common. And that's why when we do their stroke scale, we actually look at the visual fields of that patient. A lot of it is visual. They'll lose a lot of visual impairment because of their stroke. Okay? If you think about left brain thinkers, have you ever taken a quiz on Facebook? I think there's one going around right now. And I actually took it because I was curious if I was a left or right brain thinker. So left brain thinkers have been known in history as people that are more analytical, people that have more written skills, not necessarily more knowledge, it's a different knowledge, but more of a, I don't want to say smart, but like they're good at math and sciences. People that are right brain thinkers are more good at arts, humanities, okay? They're just a different type of brain and thinking. If you're a right brain thinker, you might be more creative, you can draw, you're an artist. Left brain thinker, you can't draw a stick person, okay? But you can do calculus 101, okay? So everyone has their strengths, but that kind of comes back to where your stroke's at too. If you have a left brain stroke, you're more likely to have those impairments that you were good at. So writing, speaking, those are things that you would see. These types of people for sure will have words. They can't get their words out. Sometimes they know what they're trying to say, they just can't physically say it. So it's slurred speech or the dysarthria where they can't articulate their words and it's kind of just a moan or a mumble, and it's very frustrating for the patient and the nurse because we want to help them, but we can't help them if they can't tell us. Sometimes they could maybe write it, but probably not if it's left brain stroke. So if they can't write it, they can't tell us, what do? We just have to do the best thing we can. Something simple as going to the bathroom. They might be able not to say, I have to pee, okay? And they physically are maybe paralyzed on one side and can't get up to go to the bathroom. So it can be really frustrating. Again, I wouldn't get too caught up on every single type of left brain stroke symptom when it comes to what you're going to see. But if you think back to what left brain thinkers do, it makes sense for what you're going to see. So in this person, you have a left-sided stroke, okay? So you can have right-sided problems, right? Okay, so if you're looking through this, as we're looking outside, like say we're looking this way, you can see outside your left side, but the right side is damaged. Does that make sense? Okay, left brain is the stroke, the right side is going to be affected, so that's the damage part. The right side, and you can see out the left, okay? Direct opposite for a right brain stroke. You'll see the exact opposite.
From both eyes?
Both eyes, yep. Both eyes, you can see out of both eyes, it's just only half of the visual field. And you'll see that a lot, and so what kind of problems could you see in the hospital? If the patient was facing this way, and I was walking in from this side of the room, he might not see me, or she, okay? I might startle them, or they potentially might frighten easily, and it's a threat. They've had a stroke, their thought process might not be there, and on top of that, I'm a strange person coming into the room, okay? So definitely talking before you come in, even though they might not be able to hear you as well, but introducing yourself right when you come in. Housekeeping does it all the time. They come into the room, they don't say a word, they start cleaning, and it could scare them, okay? So making sure that you introduce yourself right away. This just little cartoon kind of tells the things we just said. It might be easier for you guys to see a visual of what you would see for patients with CVAs. But I'm not going to go through each one of those because we're kind of going to go repeatedly through each one. Just think of like they're people that are good at math. They're probably not good at math when they have a stroke on the left side. If they're readers, writers, they won't be able to do those things. Okay, right brain stroke, total opposite. You have your right brain affected, either from a hemorrhagic or ischemic stroke. They're going to have the total opposite, the left-sided paralysis, the left-sided weakness, depending on how severe the stroke is. They're going to have the left visual fields affected of their eyes instead of the right, so they will see outside of their right side. Okay. Since these people are more the creative, visual, spatial people, they will have more trouble with judgment. They might be more impulsive, where they can talk, but they'll blurt things out. They don't necessarily know why they're doing it. Or people will start laughing, just bursting out laughing for no reason, and you're like, did I say something funny? I'm not sure what I said. Happens all the time with strokes, that they'll lose their thought of, or their process of, I don't know, to themselves, I guess. But you'll walk into the room and you'll say hello, and they'll bust out laughing. And so those are things they can't control, and that's typical for a right-sided stroke. These people do better with verbal instructions because they can actually comprehend it. Their left brain is not as affected as much. And so since their visual is both affected on both left and brain stroke, we try to limit our visual demonstrations only because a lot of the times they can't see you. Okay? And you don't want to get into their bad vision field because you don't know which one's affected. Most doctors will test their vision. Sometimes we can't tell which vision is affected, and it's all based on what type of stroke they had. So sometimes doctors will do the actual first one, and they'll tell you which side is affected.
Is it always?
A lot of the times, if it's a bad enough one. Some people have TIAs or slight strokes where they don't have that much effect, and they may not have vision impaired. But if it's a real true stroke and they had a huge occlusion, yes, they will have visual field. Yes. If they have a right brain stroke and their left side is affected, they can have neglect on that side where they don't even acknowledge that their hand or leg are there. So if you have a patient in the bed and they're constantly, some people at least try to move their arm or try to move their body, but some people after 3 or 4 days don't even acknowledge that this part is there. They don't look at it, they're ashamed of it, they just don't even care that it's all flaccid. Okay, so you'll see people even 3 weeks after, they just don't even care. They'll just like, they just sit there and they don't care about anything with their arm. Some people at least try it. Even though you can't move it, they'll be like, I'm trying to move it, I can't. But they still try. That's the biggest thing with strokes is getting them to try all the time. Because even when you're trying to move those muscles, sometimes you can increase the muscle inside there by doing active range of motion. Passive, well not active, but passive because you're moving it for them. Okay? So the biggest thing is not having them neglect it forever because then they're just going to be flaccid. And therapy will work with them right away. Remember our proprioception with Courtney? They basically lose that process too. So they don't know exactly how they're moving their arm in space, or they can't tell that their arm is moving in space. If I were to lift up their flaccid side, they couldn't even tell me where their arm was at. None at all. Sometimes with the left brain stroke, you can lift it and they're like, I kind of feel something, like I feel you touching me a little bit, but I can't move it at all. It's totally flaccid. So with them, they have more proprioception loss where they can't feel anything. No touch, nothing. Again, just kind of tells you the visual part. You're a visual learner, you're a right brain thinker, and you actually can see all these things and make sense because it's precise. I'm not going to go through every single one of these. This just shows that you're a left or right brain thinker. You might be bored tonight when you're studying, right? Friday night studying. And you're going through each one and you're saying, well, I think I'd be a left brain thinker. Just because you're a left brain thinker doesn't mean you're going to have a left brain stroke. That's not correlated at all. It just affects what side of the brain you are actually affecting. You might be a 90% left brain thinker, and then all of a sudden you have a right brain stroke, and that's the only thing you can think with is your left brain. Okay, so on our neuro assessments, what are we going to do for these patients as nurses when we come across them? Every single type of problem you can probably derive from, even if it's not neuro, is level of conscious changes. If something is severely wrong, most of the time some people have a level of conscious change where they're more anxious or they're not following commands, they don't look at you directly, their consciousness is just lost. And so what we can do is we do something called an NIH stroke scale. And when someone comes in with a threat of a stroke, we start this scale, and it's literally a binder. Some of you have seen it in clinicals. I showed you yesterday and Tuesday. It's literally a binder, and I have to get it out too. I don't have it memorized. I have a lot of it memorized, but you should really go by each one of these scale markers because everyone has to be thorough with these assessments. So it's going to test all your cranial nerves. It's going to test your mobility, your motor function, and also your sensory. So once you do all those things that are on this list, you have a scale number. Okay? The higher the number, the worse the stroke. I'm not going to have you memorize these numbers or how to analyze it, but just know that they do this stroke scale at the time of admission, so right when they're diagnosed. They'll do one 24 hours after, and the reason for that is to see kind of a trend and see if they're getting better or worse. And then if they don't have any more deficits, meaning they don't get worse, they don't have to do the NIH stroke scale again until they go home. So that could be 3 weeks, okay? So for sure 3 times you have to do this scale. Let's say you do it at 24 hours and they were a little worse. Maybe their scale, they had more weakness on that side. And let's say you're on a night shift at 2 in the morning and you go into the patient's room and they're completely flaccid, they can't move their arm at all, and it was a little weak before. You have to do that scale again to show that it's getting worse. Because that is formal documentation that tells them, or the doctor, that it's getting worse and it's not just something that you're making up. The formal documentation. And that's how they get reimbursed too, or how that person qualifies for a stroke rehab. The stroke rehab will look at that stroke scale first to see what they're dealing with. If their stroke scale is so outrageously high, that rehab might not take them, because before they can go to an actual stroke rehab, they have to be able to tolerate physical therapy, occupational therapy, and speech therapy for 4 hours a day. That is a lot of hours. We've had patients that are so weak on one side, they get so exhausted after about a half hour to 45 minutes. And so if they can only tolerate that much, we can't lie and say, we really want them to get help, but if the facility doesn't believe they're ready, they won't take them. The only time a rehab facility takes somebody is if they know they'll have improvement. Just because your 50-year-old dad had a stroke and he's completely a vegetable, they will not take him. He'll have to go to the nursing home. And that can be very disturbing to a lot of families because they say, well, he's had so much quality, he's 50 years old. Like, we realize that, but if you can't do therapy at a rehab facility, they're not going to take them. It happens a lot. The families get very angry. And so the nursing home might not be as ambitious to get them into the physical therapy. So a lot of families take it on and bring them home and try to do the physical therapy themselves, which is a lot of work with someone with a new stroke. But it does happen quite a bit. Motor and sensory, if you're doing your neuro checks, that'll be in your NIH stroke scale. But even though we're not doing that stroke scale every single shift as a nurse, you should still be doing your neuro checks. You'll be doing neuro checks every 4 hours for sure on these patients, unless the family refuses and says no more. But you will be attesting their motor and their sensory every 4 hours. Pupils and also level of consciousness. Okay? Their ability to write and read will also be affected as well. We know from talking to them if their speech is improving. So we can just listen and talk to them. If they're showing signs of improvement, we can notice that. Writing, that might be a little different. If they can't get their words out, we might have them write, but most of these people cannot write if they're a left brain stroke. So we may not use that as a type of communication tool. For motor, they can have so much flaccid weakness, or they can also have contractions. So they can have both sides, where they're actually contracting so much that they can't move their arm down. I've had both circumstances. There's no way of saying that a left brain stroke compared to a right brain stroke would cause flaccid paralysis versus contractures. It's just based on how severe the stroke is. Usually if it's a really bad stroke, they'll contract. And that's kind of a part of something called decorticate. You guys heard of that before? It's a posturing that they do if their neural status is severely affected, and they'll sit like this the entire time, and you can't physically get their arms down because they're contracting so hard. And that's a really bad stroke. And they're usually having seizures with that too. So there's so much pressure in the brain. That's just because of lack of mobility. If they lay in bed for so long, you will start having contractures because you're not physically moving your arms. Or if they refuse therapy for a month, they can get contractures. Yep, or you're having like anxiety too. But we really strongly force, like, I've had times I can't even budge the arm, like it's so tight. Like they're strong. Well, not strong, just contracted is what it is. But they actually recommend that you stretch those arms out day after day because you're not helping them by keeping them in a contracted motion. So they'll have you like try to push the arm down every single day. Or if their legs are contracted up, you'll have people like in fetal positions. They really have you like try to force the leg down and like put pillows on top, so it won't like you won't sit in the fetal position. So that kind of works with their mobility. Physical therapy should be working. What's that? It can be forever if it's a bad enough stroke. So our deal with nursing, even CNAs, physical therapy, it's best just to start right away, so then they're not having as much problems. Some people's strokes will never get their complete 100% thought process or body back. It's the best thing first is to get physical therapy and OT on board, and they can at least get some quality or some mobility. And you have to keep working with them. If they lose 3 days, they lose a lot. So you have to do it every single day.
I have a question. So when you do a stroke of the arm, it's like should try to stretch it out, or
physical therapy would do the first initial exercises because that's their job. That's the exercise part. And they would give you a list of exercises to do. And obviously if it's going to crack their arm or break their arm, obviously you're not going to do that. But some in the beginning stages aren't as contracted. After so long of being in a nursing home, they get to the point where it can't move their arm. Obviously you're not going to be doing things then because you can't. I couldn't physically move people's arms. There are times like that. But in the beginning parts, you should be able to move them a little bit. And keep doing that every single day, multiple times a day, to prevent the horrible, horrible contractures, because they hurt, and they are in pain. Okay, other things that you're going to see on the sensory side, a lot of these words are on here, like agnosia, apraxia. You have to be familiar with them, because I might use them on the exam, and you're probably going to say, what the heck is that? Okay, so I would actually be familiar with what those words are, because you might see them and be like, I'm not sure what that is. But yes, you have to know what those two are, and also like aphasia, alexia, agraphia, you have to know what those are. Okay. So with the sensory, they may neglect their entire side. That's the unilateral neglect I was telling you about, where they might not move that arm. Vision changes for sure. They can have ischemia to the actual optic nerve, and they can lose their vision completely. But most people will just have the half vision changes, where they lose half their vision. And then in extreme cases, you can have blind, which would be horrible because if you don't know you have stroke, that's scary already, and I can't see who's taking care of you, or you're in the hospital for long periods of time. That could be very scary for these patients. Cranial nerves. I'm not going to go down each cranial nerve and say, what is cranial nerve number 5 test? But just know when we're doing our NIH stroke scale, we are testing those nerves, all the cranial nerves. And we will be asking them to do these certain things. This is like a condensed NIH stroke scale. I ask these patients with strokes, even if we're not doing a stroke scale every day, I ask them to do this every assessment because I want them to tell me. They'll think it's funny if they're not that severe of a stroke. Like if I tell them to smile or lift their eyebrows up, shrug their shoulders, lift their hands up, they think it's hilarious if they can actually do it all. Because they're like, why are you asking me to do all these things? It's not that hard to do. I said, that's great because you didn't have that bad a stroke. But what's your highest risk of having another stroke? The first 24 hours after having like a TIA or even just like a small stroke where it wasn't that big a stroke. That's why we do this stuff every 4 hours in the ICU, because they can have another TIA at any time. And if we do have another TIA, what can we do, or a stroke? What can we do right away? Time is money, right? Thrombolytics. And if they're having a mass enough stroke, we can give them thrombolytics early enough. So it is crucial that you do this every 4 hours. Okay? But we will ask all those questions. And it'll become so second nature to you that you'll just ask them all the time. It'll be like a 30-second assessment. It doesn't take long at all. Here are the cranial nerves, if any of you are wondering. But yes, you have to know kind of general, yeah, they test the cranial nerves, but I'm not going to go down and say, the vagus nerve, how do you test for that? I'm not going to get that extreme. Learn that before in anatomy, and I will tell you one time, or all the time, that in nursing, I guarantee 90%, or maybe I'm going to say 99%, of nurses don't know all these, and they don't know how to test each one. Okay, you're not going to have to know that. Okay? The biggest thing is when you're doing your NIH stroke scale, it'll tell you what nerve is being tested. So it's a familiar, at least a familiarity there. This is something we do for patients initially. This is probably for an ER or someone on the floor, let's say, that has a level of conscious change, and we think they're having a stroke. We can ask these 3 questions, and that should be more, there should be more diagnostics done if you suspect a stroke. So obviously, we tell them to stick their tongue out. They won't be able to do it, or they'll put it just to one side. It'll just be dragging. Talking, that's the first thing that most people notice, because you'll ask them a question when you go into the room, and they won't be able to actually function, say a function sentence. They'll say something totally out of the ordinary. They won't say things in a complete sentence, and they might have some slurring of speech, and you'll think right away, they were not like this before, they could be having a stroke. And think about why they're in the hospital too. Let's say they had a knee surgery done, and all of a sudden they're having level of conscious changes, and they're having slurred speech. Absolutely, you could be having a stroke, and it's happened quite a bit. And then motor, making sure that we're testing their arm strength. Simple as asking them to raise their arm, and they can only raise one of them. And if you have these 3 things, contact your physician immediately. If you have any of these 3 simple things to look for. But most of you know as nurses, if you know your patient at all, even if you went into the room for the first time and they were slurred speech, you would at least ask the previous nurse or go look up in the patient data screen and say, was he like this last night? Because that could be a potential for a stroke. Okay, our nursing diagnoses. Ineffective tissue perfusion is probably going to be our first and foremost, number 1. If you suspect that there is a stroke, we would obviously have to go and do a CT scan to test for what? See what type, right? If it's a hemorrhagic stroke, are we going to give thrombolytics? No, they make them bleed more. So we have to do a CT scan first to make sure it's not. If it's an ischemic stroke, we can proceed with potentially a thrombolytic. So what's our time frame? 3 hours is what we shoot for. They can be given up to 6, but some research has shown that's not as effective. But 3 is our magic number. If we can get it within 3 hours, that's what we want. If they have a suspicion of stroke, we'll perform a neuro assessment, and that would be our NIH stroke scale. ICP pressuring, so that's our intracranial pressure. If they were having a hemorrhagic stroke, their intracranial pressure would increase. And we will talk more about intracranial pressure a little later when we talk about brain tumors and increased pressure in the brain. But just know during a hemorrhagic stroke, their pressures will increase. The only way to measure intracranial pressure is with an actual catheter that goes up to the brain. So you couldn't get this from a lab or a chest x-ray or a head MRI. That's not going to tell you anything with ICP monitoring. You have to have an actual catheter that goes into the brain, goes through the cranium, and it will measure these pressures. These people will be in a neuroacute hospital if they have ICP measuring. But you will have to know normals, that a normal ICP pressure is less than 15, 20, that's the max that you would see. We like to shoot for 10 to 15. That's a good number. Someone like you and I would have less than 10 for sure, unless you have really high pressure in the brain. So things that we can do, this is just kind of an introduction to ICP monitoring, but we'll talk more about it later. We try to avoid activities that would increase your intracranial pressure. So if you do have a hemorrhagic stroke, we don't want them coughing. I know it sounds ridiculous if they have to cough, but we really try to have them cough small or light. We wouldn't induce any type of suctioning unless obviously they didn't have an airway, but we wouldn't just suction scheduled for the heck of it. Okay? We want to make sure that we are preventing more increase in pressure. And then the easiest way to lower the intracranial pressure is the head of the bed up. If you increase the head of the bed, it makes the pressure of the venous return go back to your rest of your body. If you're laying flat, kind of works the same with blood pressure, right? You want your perfusion of your brain, put your head down. If you put your head up, all the pressure goes down.
Would you have increased pressure if you're with?
Hemorrhagic, yep. And that deals with the bleeding on the brain, causing a pressure in there. If all that blood has nowhere to go and it's just sitting in your brain, that'll cause increased pressures. With ischemia, you could, but it's not as likely as hemorrhagic. And we'll talk more about ICP monitoring a little later on in the PowerPoints. We'll look at our cardiovascular. We already looked at our neural. Cardiovascular, you're going to see blood pressure is pretty significant. Most likely in the 200s over 100s. That is not unlikely. See a lot. There's not much symptoms of hypertension until they're in the 200 over 100 range, and then they'll start having headaches. They'll say, oh, my head is just pounding. And you'll take their blood pressure, and you'll say, oh, yeah, I know why. Okay? If they are on medications like nitroglycerin to get those blood pressures down so you're not having a stroke, we don't want to go from 200 over 100 to 100 over 50 in an hour. We don't want to go fast. We want to go very slow. A good rule of thumb is 5 to 10 points or so every hour. Okay? We never want to see it under, that's our magic number, 150 over 100, for someone that has had a stroke or has a high potential for stroke. The reason why is because if you get too low, you won't perfuse the body. Okay? So we don't want to see them at 120 over 80, even though it's normal for everyone else. So on a question on an exam, I don't want you to put 120 over 80 because it's not right. Not considered normal for a stroke patient. Okay? Psychosocial, obviously, if they're having
like immediately after, like
if they're having a stroke, like most of the time if they've had a stroke, you'll take their blood pressure and it's extremely high. The pressure in their brain is just that elevated.
like a month after.
No, not a month after, but for sure the first
Like right away.
Right away, and then it can happen in the hospital for the first week or two. I've had people in the hospital really high blood pressures for a week or two with a stroke, and especially if they have intracranial pressure that's increased, it'll be higher too. Like I said, psychosocial, we talked a little bit about how emotional impaction can this be on your body. Most people work daily lives, and I would say strokes, most of them don't. I mean, yes, elderly is affected more, but I think I've had more 50-year-old strokes than 75 and up. Because it's those men that are stubborn, I'm just going to say that, men that are stubborn that never go to the doctor, might be farmers, they don't take care of themselves, they don't exercise, and it happens a lot. They come in that 55 to 60 range, and those are most people that are affected. They have young kids at home, their wives are still working, they're still working, and it's really emotionally unbearable to watch. Like I was telling someone, my first code was a little baby, like a 3-month-old baby. I think I cried less during that one than my 55-year-old that I took care of for 3 days that had 18-year-old kid, a 6-year-old kid, and like a 12-year-old kid, and had to watch his dad die on the bed. I think that was worse off than a 3-month-old baby. So it shows you there that it sucks. It really does suck having a stroke, especially if you are to the point where you can't move and you can't think for yourself. Most of these people will go to a nursing home. That's also a burden financially too. 50-year-olds usually don't have Medicare, right? So they might have to pay for that through insurance, and it can be a very big burden on their family if they were the breadwinner. Maybe they're the one making all the money, and now they have to worry about being in a nursing home the rest of their life. There's no certain lab that actually tells you why you're having a stroke. They can look at certain trends in bleeding disorders or bleeding tendencies, like your PTINR and your PTT. If you're having a hemorrhagic stroke, your PTT could be elevated, so could your INR, because you're actually showing signs of hemorrhage or bleeding. The most preliminary thing that we're going to do with a stroke or any type of suspicion of stroke is a CT scan. It's the easiest scan we can do. MRI takes longer, and only because you have to have a pre-assessment saying, no, do you have any internal metal in your body? Most of that time they come into the ER, we don't know their history. So a CT scan is considered the safest as well. When we do the CT scan, we're ruling out a hemorrhagic stroke. Do not want to give thrombolytics with a hemorrhagic stroke. So if we do find that they have an ischemic stroke, we will preliminary give the thrombolytics to make sure that they're not having bleeding. Okay? With a CT scan, sometimes it doesn't come up for about a day. Okay? So if you're having a stroke right now and you go in to have a CT scan done, sometimes it won't show the stroke right away. Some do, some don't. And they won't potentially give that thrombolytic if they don't see a stroke. They're not just going to give it, because this is a very serious medicine. It has a lot of side effects. So what they would potentially do is do a CT on admission, watch them for 24 hours. Remember, that's our magic window of it potentially might happen again. And they would do another one at 24 hours and see, or an MRI, either or, to see if there's any more infarction. Because infarcts can take a while to show up. Okay? So just because the first one doesn't show it, doesn't mean they don't have a stroke. They can do baseline scans, say if they're older, like 75. They may have had CT scans of the brain 10 times in their life. We want to pull those up because we want to see what they had before compared to what they have now and see if there's changes. Someone like you and I may have not had a CT scan of their head before. There's nothing you can do about it. There's no baseline scan. But for sure, someone in their 70s, 80s, I bet they might have had some scan done of their head sometime in their life. And they can pull that up. If they get admitted, we'll for sure be doing an EKG. They'll be on tele. Potentially cardiac enzymes if they feel like that has affected the heart in any way. And then for sure an echo. We need to make sure that the echo is showing any type of irregularities in the heart and maybe potentially showing signs of high viscous blood or irregular clotting. That can definitely derive from your heart and how it functions. If you have an EF, remember our ejection fraction? Remember what that means? How effectively our heart is pumping. If our EF is really low, what can that give us or what can happen? You have high risk for clots, right? Because if you're not getting an adequate pump and you're not having that good, nice pump in your heart, you can throw clots because of all the blood starting in your heart to clot. And then once it gets a pump, it can go to your brain. So if your EF is less than 50, for sure less than 40, you can have high risk for stroke. I'll finish this one, then I'll take a break. So thrombolytics, our rule of thumb is 3 hours. You will have to know what a normal, or like what those medications are. You have to be familiar with which ones to give. Remember in cardiac, we learned about TN-case. TN-case, have you guys heard of that one? It's a thrombolytic. We do not give that in strokes. So you do have to know that that is important, and that has no effectiveness in stroke, only in cardiac. We do give TPA. That's probably the number one that you'll ever see. That's always the first line of defense. Or Retavase. Those are the two that we would give for a stroke. And obviously what that does is it dissolves the clot. It is considered a clot buster. Is heparin a clot buster? No. What does heparin do? It can prevent more strokes from occurring, but it cannot fix the current one you have. So heparin might be started after the stroke has been established, after we know it's not hemorrhagic, right? We wouldn't give a blood thinner to someone that's bleeding. If it's an ischemic stroke, we would give heparin after the stroke, and we could potentially give thrombolytics as well. What are they at high risk for? Bleeding. So now we have an ischemic stroke that we give thrombolytic and heparin to. And if we give too much, we can have a bleeding stroke. It happens all the time. We have these problems of no happy medium. Okay? They've already shown weakness in the brain, that their brain can't function as well. That's why they had a stroke. And if we're inducing all these blood thinners, that could potentially cause more harm and cause them to have a hemorrhagic stroke. I've seen it happen once, and it is horrible. Because then you have the other spectrum. They've had 2 different types of stroke, and that person didn't make it because it's a very severe thing. So thrombolytics aren't usually given unless you have total occlusion, 100%. They try not to give that medication because it's so many side effects. If we have them in the hospital for a while and they've been on heparin, we can transition over to Coumadin. They'll probably be on Coumadin the rest of their lives if they had a ischemic stroke. Obviously, our therapeutic range is 2 to 3. We like to see that after about 5 to 10 days if they are accommodating well for our Coumadin. Baby aspirin, that's pretty common. Our cardiologists love baby aspirin for stroke prevention and also Plavix. Sometimes people, especially in their older age, won't be on Coumadin because it's high risk for bleeding. Coumadin is very shown effective to have bleeds. So they'll start them on Plavix and maybe a baby aspirin, and that's shown to be very effective to prevent strokes. So some cardiologists won't even, or I should say cardiologists, but North Central Heart, they're the people from Sioux Falls that come in. They'll start them on Plavix and aspirin, which aren't very invasive and they're not very high risk for bleed, and it works really well for patients. They really like those 2 meds. Ativan, that's going to deal more with your high risk for a seizure, if they have seizures, or if they're anxious from what's going on. Sometimes it can cause them to have contractures and they're very agitated easily. But if they are having an active seizure, they can have Ativan as well. All right, why don't you guys take a break and we'll come back to the rest of the drug.
Oh, and on Wednesday, my friend woke up at this face.
Okay.
Oh, God. I'm going to purposely
Okay, continuing on with our stroke medications. Talked a little bit about the intermediate stuff that we would do right away, but for drug therapy that we're going to potentially start long term, or when they're in the hospital, we will start calcium channel blockers. The drug of choice is probably cardizem, but when we have something with our blood pressure being too high, we have to be careful that we don't lower our blood pressure too much. So blood pressures and heart rates will be for sure checked every 4 hours on these patients. Remember with calcium channel blockers, you'll have a decrease in heart rate and blood pressure. We may want our blood pressure to be a happy medium, but if our heart rate gets too low, that's not good either. So we have to be monitoring both. People that have hemorrhagic strokes have a high risk for seizures because of that pressure on the brain. We will give these types of medications during that time. Dilantin, I think, is the commercial medication med of choice. That's probably one more I'd test over more often. Has anyone ever given Dilantin? You can give it PO or IV in the hospital if they were having an active seizure. Would we give someone PO? No.
Yes.
No. You give IV because if they're foaming at the mouth or if they have a potential for airway obstruction, we do not want to introduce anything into the mouth. Also during a stroke, or excuse me, during a seizure, what are some things that you would do as nurses besides give Dilantin? Put them on their side, don't put them on your back.
No pillows.
Restrict any clothing or take them off, make sure they're not having tight clothing. Protect them. If they're thrashing their head around, make sure they have soft padded rails on their beds. So if there's seizure precaution, which if they have a stroke, that's a hemorrhagic stroke, they will be on seizure precautions. And so you have to anticipate that you might come across a patient with a seizure. With Dilantin, what's something that we need to monitor on Dilantin if we've given it? They may have PO that they're getting daily, and then IV for PRN if they have an actual current stroke, or excuse me, current seizure. But if we're giving Dilantin daily, what should we be watching? There's a lab, it's actually a Dilantin lab, it's a therapeutic lab that we can look at for what's a normal Dilantin lab. So we can look that up. I believe it's 10 to 20, but for your commercials, whoever's doing Dilantin, that'll be in there, okay? And then whenever we learn from each other, that'll be on there as well. So if you have someone that has a Dilantin level of 40, are you gonna give Dilantin? No. You can have a lot of damage to their liver and kidneys. You give something alternative like Ativan for a seizure, but Dilantin has shown to be the most effective in seizures. Some of the least or the less common things that you would do are maybe not the priority. Obviously, if they're having a stroke, they might lose their sense of going to the bathroom. So incontinence is very common, or they could get plugged up because their circulation isn't as well. So we have to be cautious of people that have chronic constipation, and on top of that, they have a stroke. So colates might be introduced. Pain, depending on the patient. Some people have pain with the stroke, some don't. It just depends on each person. We would avoid NSAIDs like ibuprofen or Toradol. Those are the IV medications. Tramadol is another one because of bleeding. Okay, we don't want to introduce more bleeding. Anti-anxiety meds or potentially anti-seizure like Ativan, that would be something we'd give. This is kind of a not necessarily newer treatment, but I think of more cardiac for hypothermia treatment. If you have a person that has a STEMI or something with cardiac nature, that they might have an occlusion to a vessel, which could happen in a stroke as well, they can do hypothermia treatment to preserve the muscle. If you go to a cardiac hospital and we're going to transfer from Mitchell, they actually tell you to introduce hyperthermia. So we start putting cold packs on them and giving them cold saline. And that's going to preserve the muscle in your body. If it's a hot muscle compared to a cold muscle, think about freezing something in the refrigerator, it's going to last longer, right? Or in the freezer, compared to something sitting out on a hot summer day. So it works the same with your muscles. They keep it at about 90 degrees, what their goal is, which would make someone really cold. Okay? So they do that. It's not as common as you think because you have to have the right circumstances. If you're going from Mitchell to Sioux Falls, that's at least an hour and a half at the minimum. It might not be effective if it's not right away. And they actually would take these people to the cath lab from when they were cold like that. That's why they do that right before they go to the cath lab. Okay, another nursing diagnosis that you might come across, impaired physical mobility and self-care deficit. Obviously, they're having weakness or paralysis on one side. We need to prevent any type of immobility issues like clots or skin breakdown, potentially pneumonia if they're not effectively breathing or having good cough. Atelectasis, have you had patients with atelectasis? Most nurses won't get too caught up on that, but it just means that your alveoli have kind of collapsed a little bit and they need to be re-expanded because they're not taking deep breaths. The better deep breaths and coughing you do, the better your atelectasis improves as well. So definitely doing like your incentive spirometer, cough and deep breathe. We will introduce physical therapy from day one if they're stable. If they have ICP monitoring and they're not stable enough, they will not introduce physical therapy. They might do a little passive range of motion if they're on a ventilator to that regard, but nothing too extensive. We want to change their position frequently to prevent skin breakdown. They will be on their back for a long period of time or in bed, so making sure they have a specialty bed might be something that they need. DVTs, we can do SCDs or TED hoses. That is common in these patients. If they have a clot in the leg, like an active clot, we wouldn't put any SCDs on that if that's where they suspect the clot was coming from. But if it was just a clot in the brain, like a thrombus, we could sure do the SCD treatment. Like I said, PT, OT, speech therapy, those are all things we're going to start right away. Okay, if you're getting a patient out of bed, which side do you think is the best side to get them out of bed if they have had a stroke? Their strongest side. What are they going to do if their bad leg comes off the side of the bed and that's the first thing they go on? They're going to fall, and you're going to need more people in the room. If you have the affected side, which this person shows they're having probably a what-sided stroke? Left-sided, because their right is affected, right? Left brain stroke, right affected. They would start getting out of bed on the left side because that's the strong side. It works the same with everything else. If you have a patient that has a table next to them and they have water, are you going to put the water on the side that's affected? No. You want to put it on the side that's strong. Okay? And then we try, this is not as likely, but we try to approach them on the side that's strong as well, so we're not having them be frightened so they don't know we're in there. Okay, next nursing diagnosis, disturbed sensory perception. If they're not able to visually see you, we can do interventions to do that as well. The biggest thing is if these things don't go away, we have to teach them how to adapt to their surroundings and adapt to their new deficits. Some things are temporary, some things are reversible, but some things may never go back to their normal. So we don't like to say anything right away and say, yes, you'll be paralyzed forever, but we have to tell them to encourage them to continually work at it. Because once they stop working at it, they'll actually lose more quickly. So if you have a right hemisphere damage, okay, so if you have problems with your right hemisphere, you potentially could have activities that you can do to actually improve them so they're stronger. We want to make sure that they are doing activity but having adequate rest as well. Like we said, affected side, we want to make sure that we approach them on that side and don't go on the unaffected side. Approach them on the unaffected side. If they have double vision, they can wear those patches over their eyes, and that can help so they don't fall, because they might see something like 2 levels of floor, and they don't know which one's the actual floor. They could trip if they were helping them move. So we can use eye patches. They will use those all day long. They won't take those off, maybe at nighttime, but that's about it. We want to keep objects close. If we're going to put something on a table, we're not testing them to strengthen them by putting something on a table that's 4 feet away. We don't want them to reach and then they fall off the bed. We want to make it easy for them in the beginning so they get their confidence up, and then we can make it more challenging as they get stronger. But if they can't physically do something themselves, don't make them feel worse than they already do. Okay? With the left side damage, they can cause memory deficits. Makes sense, right? Your left side deals with your speaking, memory, definitely with your writing and speaking ability. Making sure that you're doing simple tasks. We don't want to say, put your shoes on, your coat on, and your glasses on. Don't give them 3 things to do. Do one thing at a time, speak slowly, give them an adequate amount of time, because if you rush them, they will feel more inadequate because they can't do it. So making sure that you're giving them a schedule is important, and say, we do need to have these things done today, but you don't have to do them all at once. We just have to have a nice, easy schedule. And then repetitive. If we are going to have them put or tie their shoes or button their shirts, we don't just have them do one and we do the rest. We'll have them do every single one as long as they're not getting too frustrated, but repetitive is key for them to remember how to do it. It's really hard to watch somebody put their shoes on if it's taking 45 minutes. But we can help them, but we just don't want to do it for them because that's not teaching them anything. We want to make sure that they have the adequate time to prepare themselves for those situations. And it might take that long time. Nurses get frustrated too because we want to do it for them. Or wiping their bottom. If they can do it, we highly suggest that they get the independence to wipe themselves if they don't need help. Okay? We don't want them to get dependent on everyone else. Okay, another nursing diagnosis, unilateral neglect. That's when you actually have the entire left or right side become completely flaccid and that patient doesn't recognize that side and they can actually neglect it over time and produce even more problems. Okay? We want to make sure that these people are not at risk for injury. If they're getting out of bed, they may not want to neglect, or they want to neglect one side and then they fall right over. We can get a cane for that affected side so they can kind of go back and forth. We can use that. But some people are stubborn and don't want to use walkers or canes and they will fall. We have to encourage them to make sure we're being the safest as we can. In the hospital, it's easier because we are with them all the time. We get them out of bed together. But this is more for home, like making sure that they're doing these things at home. We encourage them to touch the side that's affected. If it's not moving, we encourage them to move it. We want to make sure that they're not getting skin breakdown. Doing this will help with preventing contractures and preventing more flaccid paralysis. So making sure we're moving it. And then making sure they do a full scan of the room. What if there's a little toy on the floor from their child? We want to make sure that they observe everything in the room before they get up and walk, because that'll prevent any problems from falling. And if their visual field is affected, if they don't have any vision at all, they need to have someone in there helping them, getting up to the bathroom or walking down the hallway to their refrigerator. Okay. Next one is impaired verbal communication. Remember I talked about how some of these people, they have a thought process, they can think, but they can't get their words out and how frustrating that can be. With expressive aphasia, that's what's happening. It's not that they're stupid, or it's not that their stroke affected their reasoning or their impaired judgment. It's they physically can't get the words out. Okay? So I've had times where they continually talk to you and it's just a mumbled, moaning, slurred speech, and it's so frustrating because they might have the simplest thing of saying, I have to go to the bathroom, and they can't even tell you that. So just sometimes it's getting to know your patient and saying, let's just get on a schedule of going to the bathroom, repositioning you, whatever you need, so then we can maybe prevent some of those issues. Or if they have to scratch their side or scratch their ear or something, they can't even tell you that. Okay? Some people have paralysis of their entire body too. It just depends on how severe the stroke was. But definitely, they just might need to scratch their head.
Paralysis of the whole body.
They had stroke on both sides. They had a hemorrhagic stroke that was so severe, it affected multiple sides of their brain. So they could definitely have that. It's really bad. And I've had times where they had flaccid paralysis on one side and then just like some weakness of the arm, but they could move their leg kind of thing, where like not entire part of your body was affected, but some areas they can't. Or let's say they're 85 already and they haven't had much mobility, they're weak to begin, and they might have a flaccid paralysis of the left side, but their right side is weak because they've always been weak. They haven't been able to move. Receptive aphasia, that's when someone's actually talking to them and they can't comprehend what you're saying. like I say, let's go to the bathroom or let's turn off the TV, they'll look at you and be like, what are you saying? I don't understand. Like they don't understand what's coming out of your mouth. And that can be frustrating as well, but they don't know. Global aphasia means they lose both. They can't talk to you and they can't comprehend what you're saying. So how frustrating would that be? They can't even tell you what they want, and I can't even listen to someone else to nod my head. Okay, so it's really, really frustrating. Okay, this arthria, that's kind of the articulation part where you can talk, but you can't actually get those correct words in there. It might be some slurred speech. Aphasia is when you physically cannot get the words out. Okay, so that's kind of the difference between the two. Sometimes speech therapy can work with your tongue movements, working with the flow of air, and that can help you regain some of the speech, but it's not always effective. Sometimes it's too severe of a stroke. They can do facial exercises. Speech therapy will also teach them to do this. Smiling, raising your eyebrows, massaging, just kind of getting those muscles moving a little bit can help as well. We'll always give them one step at a time commands, speaking slowly, making sure that we're not rushing them for time because that's going to make them frustrated. And we don't want to skip over the time that they get to do something because then they're not learning it themselves. They're not actually getting the therapy. We're just doing it for them. We can use, yes, there's one correction on the slide. You have avoid yes or no questions. Change that to yes, use yes or no questions. I don't know why that had avoid in there. I looked that up last night, and that was from last year, and I changed it because I found way more research on using yes or no. Because if someone has expressive aphasia and they can't physically talk like more than a few words or just maybe one word, why would we give them a question that requires them to answer a full sentence? We want to say, do you want to go to the bathroom? Yes. Not, no, how do you want to go to the bathroom? Because that's not going to be a good question for them. Technology is definitely getting increased. It might be better on the computer than writing. Maybe typing's easier for them rather than writing. Kind of the way holding the pencil is more difficult. You could chicken peck on a computer. We could use communication boards. We use those for pictures all the time. Or we'll put a picture of a bathroom, and they can point with their not affected side that they have to go to the bathroom. They don't physically have to talk at all. They can think, so they should be able to point, right, to tell them what they want. We do that on the ventilator too. And then flashcards matches with the pictures too, making sure we're using communication other than written and verbal. Okay, impaired swallowing. This is going to be a pretty important one because what is in swallowing affecting? Airway, and that can do a lot with how we're going to take care of our patients. What's the first and foremost thing we're going to do with a patient with a stroke that potentially has swallowing problems? We're going to consult who? Because not saying nurses aren't qualified, they are, but speech pathologist is going to come in and evaluate what can they actually put in their mouth. Okay? We're not going to put anything in that mouth, not even a pill, until the speech pathologist has come in and said, yes, they can have these types of foods, these types of liquids, and they can have sips of pills or crush pills in applesauce. They'll give us recommendations. Once we know that, we can advance to see what we have to do.
What if they're like dying first?
We can do swabs. What I do is, we had a patient this week. She had a stroke and she couldn't even do liquids. Liquids. It was literally pudding. She couldn't transfer the pudding from her tongue to the back of her throat. Obviously an aspiration risk. We would not put anything in her mouth. So we took the pink sponge and pushed it so no water was in there, but it's just the moisture and the kind of the coolness that helped her with her mouth being moist.
So would they do a feeding tube?
Yes, absolutely. So let's say even after the speech pathologist saw this person, they couldn't tolerate anything. We would have to consider an NG tube or a feeding tube through the stomach. Okay, it may not be forever, but until we actually get their nutrition back online and make sure the speech or the stroke is reversed or potentially better, we could potentially take that feeding tube out. It's not saying that some people have a G tube and they can still eat. We can introduce small things to maybe get that swallowing back to normal, but for the time being, they have to have nutrition. We can't just say, oh, they're getting 50 cc's of fluid a day and a half of it, sure, that's not enough, especially since their body is still stressed and has to heal. So we will incorporate feeding tubes for, indefinitely until we need to focus on swallowing. Okay, so the first thing we'll do is speech pathologist. They're going to give us a recommendation, and they're going to give us something called a thickened liquid. You guys seen those things like nectar thick, honey thick, pudding thick? Obviously, pudding's the worst. Have you guys seen pudding water? It's literally the thickness of pudding. Not very appetizing. But it's nutrition. It's hydration. You have to do it. Chopped meats, parade meats, those are things that you would look for. Let's say you're feeding your patient now that you have your diet order, and you're putting the food in. Which side are we going to put it on? Unaffected. If this is a left-sided weakness, we're not going to put food on the side. They're not going to move the food back, you guys. It's going to get stuck in their cheek, stuck in the back of their throat. We need to put it on their right side. Okay? So putting it on their unaffected side. Let's say you put it in there, and all of a sudden they start coughing. Stop feeding them. Do not continue feeding them because they're obviously aspirating. It's not going down the right tube or down the right part of the trachea, going in there. I put a sat monitor on their finger while they eat, especially for their first couple times eating, because that'll tell me if they're actually getting airway, like they're actually breathing properly. And the speech pathologist does that too. She'll put an actual thing on their finger to make sure that they are breathing effectively. Okay, let's say they don't cough, but they have some food in the right side, that's the unaffected side. All of a sudden they start eating it and some stuff starts dribbling down their affected side, like water or parade meat. What would you do then? We wouldn't suspect aspiration. They're just weak on that side. There is stuff that gets dislodged over there. We would tell them and say, just so you know, there is stuff falling down your face. We'll direct it to the other side because they need to acknowledge that that's happening. Remember the universal or the unilateral neglect? They don't want to they neglect all sides of their face. So maybe taking their unaffected hand and feeling it, they can feel it on their face or move the food up so they can actually eat it. Or taking their finger and putting it to their unaffected side. Okay? Those are things we encourage them to do. What position are they going to be in?
90 degrees.
90 degrees. I don't want 89 degrees. I want 90 degrees. Especially for their first couple times until they get used to it. When they're chewing, what do we want their head to do? Tuck their chin. Okay, that's going to cut off your trachea. So then it goes down your esophagus. It's going to help with aspiration. Okay? So you may have known some of these, but you may not have. But every single time you have a stroke patient that's severe, you have to make sure that they're doing these things. Because they will have a high risk for aspiration. If they cough, or their sats drop, or they look blue, stop feeding them. I've had CNAs that just keep feeding them, even though they're coughing. It's like, what are you doing? They're coughing. It's going down the trachea. Okay, some people just don't know. A CNA can help the person feed if the nurses kind of educate the patient and they get it, and the patient's not having problems. It's okay for them to feed them. They do it all the time. They're called feeders. Okay, just as long as they're aware of what's going on. Okay, stroke patients will have urinary and bowel incontinence, especially if it's affected a more severe stroke. We'll want to start bladder or bowel programs. Every 2 hours is a good rule of thumb to get a bedpan or potentially a catheter Foley. We can put that in there as well. We want to encourage a lot of fluid intake. 200 cc's for a stroke patient is pretty difficult, but we can do IV. We need to do IV intake until they actually get evaluated for their swallowing. Potentially putting post-residual voids. If they pee and you still feel like they have a urinary retention, you can do a bladder scanner where they actually see how much urine is in there, or you can put a catheter in their bladder to make sure that they're not having residual. Because what are they at high risk for? Infection. We don't want to have too much fluid in there. Okay, the best thing is establishing a routine. Stroke patients do not do well with chaos. They do better with a good routine where you do the same things every single day. They do their therapies every time the same day. Because if it's all over the place, they get confused and they get anxious. Even if it comes down to crushing their pills a certain way, they'll start getting more familiar with how you're doing things, and they like routine. They respond well. Put like an Alzheimer patient in the hospital that's out of their routine and it's out of their element, what do? They're constantly agitated, anxious. They're thrashing around. They get very, very anxious. So the same thing with the stroke patient. Routine is key. You've heard apple or prune juice kind of helps the motility of constipation. That's always good as well. Stool softeners, they'll be on those from day one. If we can't do the swallowing, we'll have an NG tube in. We'll crush their pills and put those meds down their NG tube. So you're probably wondering, well, how can they get all these PO pills if they can't swallow? Okay, we will. They can put in their NG tube. That one that you saw on Tuesday was just too small of a tube.
Oh.
That one was just like a 12 French or something. You would do like a 16 French for their nose. That one was just for tube feeding. But yes, you can put meds down the NG tube. You should. It's a great source to put them down. Okay?
You're saying it's a crunch.
Yes, you wouldn't put a whole tube. It's funny for me because you haven't seen it, but a pill like those big horse pills for potassium, you wouldn't put that complete on NG tube. You crush it up, put it in water, like you're bypassing the swallowing test of your body. And if it goes into your stomach, your body's going to put a whole bunch of acid and bile and water and digest it. We do the digesting before it goes down. We put water in the pills, circulate it, and it'll literally be dissolved bits.
What if it's like a
They try not to give those, or they give them by IV if they can prevent it. But the pharmacy will say you cannot crush this pill, and they'll tell you that because they'll know they have an NG2. But I'd say 90% of pills you can crush, or the capsules, even like those Prilosec that you can pull apart, you can put those in there too. It's just like your extended release Cardizens, those things, which they would give through the vein until they could actually swallow. So yeah, they do that kind of stuff. Okay, I think we did cover those. Bowel and bladder, it's pretty common, and we did that with spinal cord injuries too. The interventions are pretty similar. Okay, so now we're going to go home. What are we thinking about going home? We talked about inpatient rehab. Remember, that's what I'm trying to think of, the one in Nebraska. It must be the Madonna one, the one I always think about. But that one there, you have to have 4 hours of tolerant physical therapy, physical, occupational, and speech combined. If you get an hour and a half of each, it doesn't have to be 4 hours of PT, 4 hours of OT. But combined, you have to be able to tolerate 4 hours of therapy a day to be qualified for one of these rehab facilities. They will not take you if you can only do 2 hours. And there's a lot of times where you can't. They can't physically, they're so fatigued or they're not stable enough, they will not take them. And then if that's not the option, if family can't take them home, they will go to a nursing home. And then from there, they may not be there forever, but for sure temporary if they have to get their strength back. When they go home, we want to make sure their home is, satisfied to the actual stroke conditions. We want to make sure that there's no loose rugs. Stairs are going to be inevitable in some people's area, but having the right, railings and going upstairs if that's the case, if they can go up. The bathroom is going to be huge. It's so slippery inside the bathtub. Anti-skid, things for the tub, handrails, anything that you can think of that would help them be more handicap accessible. Health teaching, this is very high emotional stressor on people, so depression is very common for these patients to experience. You'll see a lot of stroke patients that leave the hospital on an antidepressant. A doctor just starts it because they will be very depressed if they can't do the same things they did before they came to the hospital, especially if they're aware too. That's almost worse. Sometimes you have patients that have no idea what's going on, they didn't know they have stroke, they're not necessarily a vegetable, but their thought process is gone. That's almost better than someone that has the thought process and they can't physically do the mobility. Okay? Have you guys ever heard of respite care in the hospital? It's something that they can bring people from home into the hospital. It's kind of like a hospital daycare for patients that have more skilled things to do with them. So if patients' families are taking care of their family member 24 hours a day and they're physically exhausted, they can take them into respite care, like for so many hours a week, and kind of just get away, or have that time to sleep, or have that time to go grocery shopping, whatever they need to do. Some insurances pay for a certain amount of hours a week. Some insurances don't pay for it. So it just depends on what kind of insurance you have. I've had times where there's people that have 20 hours a week of respite care. So they might use those times on they probably wouldn't do it every day because that's a lot of stress bringing someone in every single day. But they might take 2 of those days or 1 full day where they just are kind of away. And it's not a bad thing. It doesn't mean you're a bad person because you can't take care of your family member 24 hours a day. This is very time consuming. This is something that you might have to change their depends every 2 hours or every 4 hours. It's a lot of stress on your back, having to move them, turn them, feed them. So it's not a bad thing. But once it gets to be too much for these people, we do recommend nursing homes because you can't be with someone 24 hours a day. You'll kill yourself. There's just no way you can do it. So we do recommend, and we assess them too. When they come in, if we see that the patient's family is so stressed out and they're not taking care of themselves, we would actually report that to social services because that's actually a burden on them as well, and they need to bring them into a skilled facility because they may not be giving them the most effective care. And then we always have our support groups and counseling. Sometimes the counseling is just going for coffee with your friends and talking about your loved ones that have had a stroke. It may be as simple as that. A lot of people in this community, and every community, has had a family member with a stroke, and it is a lot of stress on the family. So just communication and making sure that you're keeping those open is what you need to do. Okay, some other things that you can see with potential hemorrhagic strokes. Hydrocephalus, I know it's water in the brain, but you can also have an increased hemorrhagic fluid in the brain. You can have some cerebrospinal fluid that potentially can escape, and it can cause that water in the brain feeling. Intracranial pressures are going to be how you monitor this. You can have intracranial pressures increase from water, CSF fluid, hemorrhage, anything that's a pressure in the brain that's increasing. If you do have signs of hydrocephalus, you can have changes in level of consciousness that deals directly from the pressure in your brain, the shifts in your brain, potential headache if it's forcing that pressure on there. You'll always do pupil changes every 4 hours. If there's any notice of change, meaning let's say they go from a 3, size 3 and they're reactive to a sluggish or pinpoint or fixed, you need to let your doctor know that. If there's a lot of pressure on the brain increase, seizures will be common. They always have some PRN seizure medication, and the choice is usually Ativan or Dilaton. Let's see here, vasospasm, that can be another complication where you actually have the vessels in your brain will spasm back and forth. And if you actually have it to the point where it's so tight or it's spasming that much, you can cause actually more ischemia to the brain and potentially more strokes. So that can happen from the blood pressure being too high. That's one of the most common things you'll see, and it can cause more infarction. So usually medications to release or to reduce vasospasms will be the one thing that we give for those patients, because their blood pressures will be really high. Okay, other complications, we kind of talked a little bit about this, but what they can actually find. Level of consciousness would be your first for anything, especially an NCLEX question. If you see any change of level of consciousness, that is a huge part of your questions because there's something going on in the brain usually. And if your brain is affected, your level of consciousness will be the first early symptom. Okay? And most people don't even witness it because they think, oh, she's old, she's senile, she's confused. You don't think about it, but you have to know your baseline of your patient to actually know. Motor and sensory, we think about reflexes, are those reduced? We think about, are they having increased weakness and paralysis? Are their speaking habits getting worse? Those are things that we can look for clinical signs. And we can always have problems with rebleeding. We have the aneurysm in the brain, that's the outpouching that can happen, or your AVM, remember that we talked about that, the AV malformation? That's when you have no capillaries and the artery and veins can basically connect, and it causes a blood communication problem. Okay? And that can cause more bleeding in the brain. So we usually try to fix the AV malformation early in life, but sometimes it's too late and they can bleed and die. So those are the people that if they die before the age of 20, it's probably because of AV malformations or potentially aneurysms in the brain. I think there was a lady in Mitchell, she was like the eye doctor, I don't know if you guys remember that, like last summer. She was like 27 years old and she died of a AV malformation rupture, like an aneurysm in the brain. And she was like a pretty big optometrist in town. I don't know her, but she was in the paper and everything. If you're having signs of AV malformation, you can have increased headaches or more severe headaches. Nauseous and vomiting is really common. But that is something that if you have nauseous and vomiting, are you going to run to the doctor? No. But it's very common in these people. And always your level of conscious changes. Okay, so how are we going to fix these problems if there is an aneurysm in the brain? Angioplasties don't just work for carotids or your cardiac arteries and veins. You can do a carotid angioplasty. And what they do is they actually go in and they can open up the vessel and clean out that plaque in there. And it can catch anything that goes past there with a little stent they put in. So they usually put stents in the brain to open up those vessels if something's very narrowed. I don't think I'm going to go through these videos, but I uploaded some of these videos last night. If you go on TigerNet, they are on there if you want to look at them. Kind of helps you introduce the learning. They can do an endarterectomy where they go in, usually a carotid artery. If you think about stroke, the biggest arteries going to your brain are your carotid arteries, and that is usually what is affected for a stroke, the plaque in there. And so they'll do carotid Dopplers to see if there's 90% plaque inside one of the arteries, and they can go in there with an endarterectomy and cut out those clots. They open up the artery, take out the clot, and then sew back the artery up. So essentially you're getting rid of plaque. That's what they're doing. Both of them work kind of similar for getting rid of any of the plaque buildup in there. They just do it a little bit different way. For the exam, you won't have to know exactly these procedures. I'm more worried about complications after, if they have hemorrhage or bleeding, that kind of thing. Infection, because you're actually going in, some of these are in through the craniotomy, like going in through the head. And so you could potentially have, cerebral spinal fluid leakage with that as well. But for the actual procedure, I wouldn't get too focused on how these actually work. It's more for the fixing of a clot or the plaque buildup inside your arteries. A little more on the AV malformation. I actually want to show you this video because I think it's really good. A lot of you probably still don't know what AV malformation is. I don't blame you because it's kind of a harder concept to grasp. But I want you guys to watch this video. It's only like 45 seconds. Pretty small. Not the whole. I don't think it has any sound, it just like shows you. Your arteries and veins are just like spaghetti. They like are together. That's what AV malformation is. And that's why they like can connect together and cause bleeding or rupture because of like the force in between. They don't have the capillaries to go through. So what they do is, it kind of shows what. Yeah. Usually MRI will be better. So the procedure that they can do if they find it early enough is, some people you don't find this before they die. That's how severe it is. But if you do find it, they can go in. Okay, so they put this catheter in your brain in the actual vessels, and they start putting this they call it an embolus. It's kind of like a clot, but they're clotting off all those veins and arteries. They're basically putting this solution in there to harden it, and it cuts off all circulation to that part of the brain because you're not using that part of the brain. It's just extra arteries and veins that you're not using. Okay, so the normal blood flow goes like right here. You want it to continue this way. So when it outpouches like that, it's kind of like an aneurysm. If you think about aneurysms that have outpouching, the blood gets stuck in there, pressure builds up, and that's why they have these problems. So it develops this thick, almost like a clot in there. And now your blood can go back and forth. So that's how they fix it.
Is there just spots in those?
There's usually just one. When you have an AV malformation, there's just one area that this is affected. They don't have 10 of them in there. There's just one. But yeah, they just cut off circulation to that point, and now they can have good blood flow. And then essentially that dies, and they can take that out. Yes.
Are they not worried about it
No, because after a while they'll take out those veins in there, and it kind of becomes just like a scar tissue. Is essentially what it is. Yeah, it's not.
You shouldn't really like moms.
You shouldn't. No. And they found that that's actually least invasive because they go up through a vein or artery. They don't go through a craniotomy. You don't have to open up the brain to do this. You can go up through one of your artery veins inside your body. Okay. Or through angioplasty or an angiogram where they go up and they put dye everywhere. They can see everything in the whole body.
I feel like I need to get one of those too.
It's not something you do for volunteer.
Pro black.
Yeah. I'll just get that done. But no, and they would see an AV malformation on a CT scan. So they wouldn't just go exploratory looking for this if they suspected something. But that's basically what it is, and they can do those.
That you have one.
Sometimes it just comes out they have a headache or something. They have frequent headaches. They'll go into a CT of the scan of the brain and be like, oh, look what we found. We found this on the brain. So it may not be even for related reasons. It could be something totally different. That's why a lot of people die with this, because they don't even know they have it. Okay, so it's pretty quiet disorder. It doesn't necessarily say, hey, you have an AVM malformation. Okay, but it's very similar to an aneurysm because of the outpouching.
Do they get headaches?
Not necessarily. That I kind of threw that out there as people might have frequent headaches, and that's why they get an MRI of the head, and then they find this. But there's usually no symptoms of this, nothing, except for bleeding and rupture, and then you die.
And then you die unexpectedly.
Yeah,
Why not go get an MRI and check it out?
Because 99% of the population doesn't have this. I would say 99.9% of the population probably doesn't have this. So you're not just going to go exploratory, look for clots in your brain, aneurysm.
If I was a lottery, first thing I'd do, I'd say take an MRI of my whole body.
Yeah, and then you'll have like blood clot and die because you probably had a complication or something.
Find anything wrong with it.
But yeah, it's not very common. But if it is large enough, they can do this over several weeks, like that little emboli that they put in there. Sometimes it doesn't happen right away. They can put a little in at a time, and it can go over weeks if it's a really large one.
I actually have a second cousin who has this,
Really?
and she's still alive.
Right. I mean, if you fix it early enough, you can fix it.
Here in Mitchell, and they treated her a stroke where the airlift fault, and that's what actually they actually didn't have time to do any scans or anything where they airlift it out.
Oh, really?
But yeah, he had the whole he had so much swelling on his brain from all the blood. Like, he had the whole
Right, because you can bleed from these. This is what
shot
happens.
put in place.
Exactly.
He's alive, but the rehab is done
Right.
forever.
If I see a person, like their history on their, like when I get an admit, I go look through all their history. I probably have seen this on their history 3 times, which is not very common. But when I see it, I'm like, oh, they have an AV malformation. Like, that's a big deal. Really big deal. So you always want to be cautious that they have this disorder. Okay. So this just kind of tells you what they did. This is another picture. I feel like this picture doesn't do justice for that video and how they explained it. But essentially, this is like they can put the balloon in there and that plaque buildup or that like scar tissue they develop. And then over time, they can maybe cut that AV malformation out. They don't need it anymore. The circulation's gone in that area if they do it appropriately. Okay. So let's see what else here. If they have an aneurysm in the brain, they can obviously do surgery. But sometimes if they have an aneurysm, they have to go through an actual craniotomy. Can have a high risk for infection because you're exposing that entire dura to the entire air during surgery. So they do look for patients that potentially, after surgery, they look for cerebral spinal fluid leak, and that can be like a sign of meningitis. Or if you have nuchal rigidity of your neck, you have really severe neck pain where you can't move it, they might suspect you had some meningitis from that surgery. During the process of an aneurysm, if you suspect an aneurysm, sometimes you can suspect it. They have a lot of pain. People that have very painful headaches, they can have aneurysms inside the brain. Not saying that someone's going to have a very bad headache and you're going to go, oh, they have an aneurysm. But we like to have a decreased stimulation because that can cause more problems, decreased stress on the body, and also increasing their comfort. I had a patient probably 2 years ago that had an abdominal aneurysm. We didn't know it at the time, but we thought it was urinary retention, and that's why she was like an elderly lady, and she constantly was just irritated. She couldn't stop moving her legs. We thought she was in tons of pain. And we checked the bladder scanner, and it said 1,000. So we're like, okay, she needs to have Foley put in. But the Foley in, nothing comes out, like 50 cc's maybe. We're like, what the heck? I just didn't think it would be a blood. I just kept thinking it was urine, we're not putting the catheter in properly. It's not in the right place. And she just kept getting increased pain. We kept giving her morphine all day long, and finally she ruptured. She had a ruptured aneurysm. Her belly kept getting bigger and bigger until she was literally 9 months pregnant. She died of her aneurysm. So things for increasing comfort, it's very painful. I feel like that was the worst death that person I had ever experienced because she was in so much pain from this aneurysm. Same thing with the head. It ruptures in your brain, painful. You will die, but it is very painful. They will have a painful death. Okay? Like all that pressure in your brain just gets built up, and then explodes. And then you have all that increased pressure in your brain. It has nowhere to go but stay there. So it is very painful. If they have problems with surgery, we do like to recommend that after surgery, we're still keeping that non-stimulus environment. We tell family members not to come in right away because it can be very stimulating to them. But we usually try not to do it. When aneurysms are evident and they actually fix them, they'll clamp them off, kind of an interesting technique, but when you have the outpouching, it's like this. They actually take a clamp and they twist it or clamp it off, and so then that way blood flow can go through. That's a little more invasive and a little more risk for bleeding. But they also can do, like there was a video I didn't show you, but they can go in with like these foils, they call them coils, and they essentially make their own plaque or make their own emboli, like I was telling you about the AV malformation. And it keeps doing that until it's completely full of that, like they call it scar tissue. It builds its own scar tissue, and then it can have the blood go through. So they can fill it with coil, or they can twist it and cut off it completely. So it's kind of interesting. But that's if they find it early enough. Sometimes the aneurysms are too far gone, or they start leaking and they explode, and that's when it's too late. Usually your time frame, if they're in a perfect environment, but they were in Sioux Falls next to a heart hospital, if their aneurysm ruptured, you have about an hour to fix it. Okay? So most people in Mitchell, they won't make it because they can't get to there in time. So if you have a perfect environment where you're 5 minutes away from the hospital and it ruptures, and you'll be able to tell it ruptures because it'll hurt, and also you'll have level of conscious changes. They'll probably become comatose. They'll go to that doctor anyway. So and your belly will start to fill with blood.
The doctor know that, right? You have to.
Most of the time, if they suspect something they don't know, they do a CT scan. It takes 5 minutes. And if they're in the right facility, like they were at Vera Heart Hospital, they take them right to surgery right away. It'd be a stat procedure. They do it within the hour. There'd be no time to waste. But this is the coiling that I talked about. I did add this because it's kind of a cool process. If that's your aneurysm, they put this coiling and they put tons of it until it's completely full, and it stays there. They do not take that aneurysm off. Okay? And so the blood, they might get a little pouching here, but it keeps going. It's kind of a cool process. I've never actually seen that done or had someone do it before. But if you have an aneurysm that's just small, a little outpouching, they will go in and fix it right away. They can. Radiology just usually is part of the process where they put in like an angiogram. They can see this vessel through like through a CT scan. They're guiding it at the same time. They're not open. Nothing's open in this area. You're not doing a craniotomy. You're going in with like an actual catheter, and you can see it guided through this angiogram, and it goes right into the brain. But again, don't get too caught up on the procedures. It's just to show you what they do for aneurysms and what the potential complications could be. Okay? So I wouldn't go too far into, well, do I have to know the difference between this procedure and an endarterectomy? No, do not. Okay? So don't get too caught up on that. Okay? So now we have intracranial bleeding from our hemorrhagic stroke. From our hemorrhagic stroke, what do we need to do to release that pressure? Well, in some circumstances, we potentially would need a craniotomy, where you actually take part of the skull off, and you can relieve some of that pressure. People that have fallen or car accidents that have severe intracranial pressure increased will have to have it, because there's nowhere for your space to go. You have to release that skull fracture, that skull from there. It doesn't mean you won't put it back on there. Remember that little kid I told you that was a shaken baby, and we took his craniotomy, or he had a craniotomy, took the thing off, and they put it in his belly for like 3 weeks until that was gone, and they put it back on there. I'm not sure why they do that, but that's what they do. And that helps with his intracranial pressures. Okay? The way they measure the intracranial pressure is they put a catheter directly into like the dura of your brain, and it measures it at all times. You have to, as a nurse, be cautious that this can cause meningitis, a very severe infection of the brain, because you're exposed. You literally will have patients that have exposed brain. Okay? They keep it moist, and they can sometimes just have like a shield over it, but they will have a potential opening of their brain. Okay? And those patients will be in a neuroacute. You won't see those usually, unless you work at Sanford Acute. Let's see here. We will talk more about like when we talk about brain tumors, we'll go into intracranial pressure more, but just kind of giving you guys a taste of what that is. Again, I'm not going to go through every single thing on this diagram, but this is a wonderful PowerPoint. This is like what I would probably study over. Gives you everything on strokes and what you would see, and probably the things you're going to look for in an exam. Okay? So if you are a visual learner, this is probably done for you. It's a good little slide for you. Okay, let's do our PowerPoint. Oh, are there other questions? I don't know why. We'll see if it works. Someone respond. That's closed. We can answer if it's not that big. All right, we're just gonna answer them because I want to get through this. The nurse is planning care for the client with weakness of one side on the right arm and leg. The nurse incorporates in the care plan to place objects where? The weakness of the right arm. Within the client's reach on the right side, would we do that side? No. Within the client's reach on the left side?
Yes.
Yes. Just out of the client's reach, so we're being mean to them and making them move. And then just out of the client's reach on the left side. Seriously, that is what we're doing. I think that's mean, but it may not be intentional. Okay, you might put the table next to them and they're like trying to reach, so it may not be totally mean, but right. So number 2 is the answer. Okay. Okay, the client with the CDA has residual dysphagia. When a diet order is initiated, the nurse avoids doing which of the following?
One.
Okay, why are 2, 3, and 4 wrong?
It should do that.
Okay, we want thickened liquids. Usually they have to have thickened liquids. Place food on the unaffected side. We do want to do that. We don't want to put it on the affected side and then they choke or they can't get it down. Allowing plenty of time for chewing and swallowing. If you are a feeder, or if you ever have been at a nursing home, you know how time consuming it is. Okay? Okay, the nurse has formulated a nursing diagnosis of unilateral neglect for the client with the CDA. Which of the following strategies is not used by the nurse in planning to help the client adapt to this method?
Right.
Okay, that's the wrong answer, right? Removing the commode and chair to the affected side. Okay, place bedside articles on the unaffected side makes sense so they can reach and get them. Approach the client from the unaffected side so you don't frighten them or startle them. Teach the client to scan the environment. Always before they stand or move, they need to scan the entire environment because they might not have visual field vision on one side. The nurse is trying to communicate with a CDA client with aphasia. Which of the following actions by the nurse is least helpful to the client? Moving everything to the side.
Push it.
Okay, good job. Speaking to the client at a slower rate. Completing sentences that client cannot finish. Looking directly at the client during attempts at speech and allowing plenty of time. Right. Don't finish their sentences for them. It is so easy to do. If they're like, I need to go to the bathroom, like you just continue, it's so instinct to do it. But like, just let them try to thought process and try to be patient. Oh my God. We don't have like 2 more slides left. Oh wait, I did go forward. Sorry. Okay.
No.
Learn the last one. Yeah, I know. I go back. Can I go back twice? Okay, don't move. All right, the client with diplopia has been taught to use an eye patch to promote better vision and prevent injury. The nurse evaluates that the client has correct understanding of the use of the patch if the client states to do what? We didn't really talk about this, but a lot of people have to use those patches. You guys know it's probably 3 or 4, right?
Yeah.
You have to wear it all day long, but they can alternate it each day. So like if they want to do 1 back and forth. Okay, so 3 is the correct answer. Cool. All right, we'll pick up with we'll pick up with traumatic brain injury, major 50. That's good. I was hoping to make it 50. Movies.
Man, what a good surprise for today.